Okay, good morning. We are here in the Healthcare Rule Breaker studio, and we are with Kali Dayton,
It's
who's coming to Kaylee. Did I
Yeah,
get it wrong?
I know. I didn't choose the spelling.
I knew I practiced. I
No
practiced.
worries. You had
I
it right
still messed
before.
it up. Okay, Kaylee Dayton. I'm so sorry. Who's here with us today in the studio? I'm already being a rule breaker with messing up people's names. So we'd love to hear your story. If you want to just jump in and tell us about you and the work that you're doing.
Absolutely. I'm Kali Dayton. I'm a critical care nurse practitioner and CEO of Dayton ICU Consulting. I help teams become awake and walking ICUs through mastering the ABCDEF bundle. I started my career in critical care in 2012 as a nurse, and I had the great fortune of working in an awake and walking ICU, meaning that in this high acuity medical surgical ICU, almost every patient was awake right after intubation and mobilizing, doing their highest level of mobility, which was usually walking, within 12 hours after intubation and throughout their time on the ventilator. And I thought that was normal, was brainwashed to think that patients are always going to be writing on a clipboard, texting to me while intubated, and walking up the doors at the end of their critical illness. After a few years, I became a travel nurse and realized that that was not the norm, that the rest of the critical care community had this rule that every patient is going to be sedated after intubation and throughout their time on the ventilator, that continuous sedation and mechanical ventilation are married. And that was bizarre to me. But I went with a normal culture. And so I did that for a few years. And then I returned back to the Awake and Walking ICU because I was really tired of the workload, the lack of humanization, and the poor outcomes that I was suffering from with my patients and my own career. So I did that in the Wake and Walking ICU during grad school and ended up working there also as a nurse practitioner. And I started the podcast, Walking Home from the ICU, to disseminate survivor perspectives from survivors themselves, to share what it's actually like to be in medically induced comas during and after the ICU, to share perspectives from my own colleagues to say, yes, we are keeping patients very awake, very mobile, and researchers that shared why this is so important, why this is life saving. But then I realized that clinicians and teams need so much support to make this radical transformation. So I brought together a team of experts, and now we provide training, education, and consulting to help teams go all the way and actually become awake and walking ICUs.
Okay, well, as a critical care clinician and someone who's been like spent my career as an ICU nurse and an ICU clinician, I can have a utmost respect for how challenging it is. One, to convert that thinking, right? To convert people who've practiced inept of intubation, sedation, and leaving patients like that for multiple days. But I can also attest to the muscle mass that people lose, the functions that people lose, and the how it severely impacts those patients and their families, right? Because you're sitting there and you're lying and you're watching your family member not move, and you don't know if they ever will. You don't know if they're going to wake up, and it's just got to be so cringing. And I know Crystal has had a recent impact of critical illness, and I'll let you share your own story if you want. But I do have a question.
Mm-hmm.
So when you're talking about, you're going in and this is like a huge transformation, right? Can you share a little bit about what empowers you to continue to fight through like those challenges that I know you're meeting when you're going in and you're really working through transforming a team from their traditional, sleep after intubation process to their awake and walking process?
I come equipped with 7 years of experience in an awake and walking ICU, knowing very clearly that it is also having done.
Do you mind? I'm sorry, we lost you for a second. Will you repeat that?
Sure.
You were
Yeah,
sharing that you come from 7 years of experience, so
sure.
sorry about that.
No, it's okay. So I come to these teams equipped with 7 years of experience in an awake and walking ICU, having done it myself, seen it myself, developing those tools. I've now done this podcast for 5 years. I have been deeply immersed in the research, trying to figure out why this works so well, what it takes to get there. I've also now trained 13 ICUs.
Oh my
So
God.
I've helped these ICUs through the transition. So though every team is unique, I'm always learning as I go. There are different challenges everywhere I go. I also have enough experience to say, this challenges we're facing is not unique. It's not the end. We're going to hear some ideas, some solutions. But also, I also carry with me the voices of dozens and dozens of survivors that I've interviewed, spoken to, interacted with. And so that especially brings in like almost a black and white picture for me when I'm on these units and I see patients laying there. I don't see them as sleeping anymore. I see them as suffering horrific brain injuries, trauma, life altering, life threatening conditions that we're inflicting. So I carry that with me to have the courage to speak out, to push through, to not back down, and to guide these clinicians to do the right thing so that they can experience success. So it's been a challenge when I go on site, even after I've done lots of consulting, I've done webinars with these teams. A lot of times these nurses or even respiratory therapists have their guns loaded for me. They're not excited to see me. They're scared. They're hesitant. I mean, me telling them that their patients can and should be awake and mobile as a standard for the most part is like telling them the world is flat. It breaks every rule that they've been culturally trained to believe in and practice. So they think I'm insane. They think I'm just making it up. So when I'm on site, I get to go to the bedside with them and guide them to do these things with their patients, and they get to see success. So having seen that so many times now and having those experiences, that just further fuels me to approach the next team with even more confidence, more expertise, and more perseverance.
Man, yeah, I love what you're doing out there, and I so appreciate the resistance to change that you experience. And it seems so just, especially you were raised up in an organization where that's the culture. So your mind is blown that it exists in any other way. And their mind is blown that this is even possible. And like, who are you to come in and tell me to do this, right? And
Yeah.
so Alyssa mentioned I have some recent experience. My oldest son had a bad motorcycle accident over the summer, so we spent a lot of time in the ICU and lots of time in the OR. Fortunately, no intubation, but seeing and knowing what's the best practice out there and trying to advocate for and change the way that it's done. And it seems so like common sense. Why wouldn't we do this for our patients? Why wouldn't we do this for the loved ones of others? But it's so, even though ABCD, I guess the E and F have came along more recently, but it's not like it's some brand new thing. And yet we're still not able to implement it in all the places. So I love that you're doing this work. It's so impactful for families and the patients that you serve. I'm curious how you get, so in my world, it's leadership development and helping people manage the change. And why would we do this? What's the ROI? So when you're out there and you're trying to do this for all the right reasons, for the patients, for their outcomes, how are you speaking to those leaders to say, this is what it's worth? Here's the ROI. Here's why you should invest in it.
Yeah, I spent years with my podcast trying to speak to the heartstrings of clinicians.
Yeah.
That is the language they speak, but that doesn't necessarily bring the wide scale changes and especially the resources to make that happen. So now when teams approach me, and sometimes it's a nurse manager or even a bedside clinicians, and I'm like, let's just talk money. Get me to your executive leadership team. Let me just explain to them that they can spend thousands to save millions.
Yes.
Once we see it that way, it's a duh, right? So we talk about throughput in the hospital when patients are on mechanical ventilation and in the ICU and then in the floors for days, 2 weeks longer. That's when you start building up in your your ED with the boarding. You've got all these patients waiting to get to care facilities because they're so delirious, so weak. Now they need to go to care facilities, but those facilities are already full of the patients you sent to them last week. So it's a huge system-wide problem. There is vast research showing that the return on investment is huge. For example, there's a financial sensitivity analysis that shows that for 2,000 annual admissions, the annual cost of these kind of programs is about $114,000, but the annual savings is almost $5 million.
Yeah.
But we're not doing it. And when I explain this to the financial stakeholders of hospitals, their jaws drop, their eyes get large, usually because they're like, well, oops, we just downsized our rehab department. But because they're not making these decisions armed with the evidence. So that's one of my most important jobs, is to go and make sure that these high-level executive leadership positions understand the big picture. Because again, they don't know that what we're doing in the ICU is not necessary. They just assume the ICU is doing their thing. They know what they're doing. It's necessary for patients on mechanical ventilation to end up that way for weeks.
Right.
And I am the crazy person that comes in and says, well, actually, yes, they come in with critical illness. Yes, they need the mechanical ventilation for their diagnosis. But the care that we provide leads to all these other complications that ultimately end up with prolonged time on the ventilator, the tracheostomies, the LTAC placements, the falls, the self-extubations, the line removals, all these things that you're worried about, these hospital-acquired infections. A lot of that is rooted in what we do at the front end. So let's put resources into the front end. Let's get mobility techs. Let's get training. Let's overhaul this whole process, and it's going to impact the entire hospital, make it more efficient. So once they understand that picture, then teams finally get the resources they need. This is the biggest card we can play for safe staffing.
Yeah.
We can't afford to sustain what we're doing currently in our ICUs. And yes, the ABCDF bundle is not news.
Right.
The ICU I came from, they published a study on this in 2007.
Yes.
People act like it's new. And hospitals a lot of times will have that box checked for the ABCDEF bundle because it's implemented in their charting systems. There are certain things that all the clinicians have to chart on. So they think, and they say, and they tell me, oh yeah, we practice the bundle. And I say, okay, so what percentage of your patients are out of bed? And they say, ooh. So we look into the data, and it's like 1%. So the bundle has been perceived as things to chart on, just awakening trials, like assessing for extubation. They're not using the bundle to keep patients awake, communicative, autonomous, and mobile, which is the true objective. So I'm not necessarily bringing in something new. I'm just saying what you thought it was, these rules that you tried to set for this bundle are actually detracting from the overall mission. You're not having the outcomes and benefits to your hospital, clinicians, and patients with the way you're practicing the bundle. Here's what the bundle really is. And that's when they finally realize, okay, we do need help.
Yeah, you nailed it. We oftentimes put things in as done, but we really haven't measured the outcomes of, are we truly doing this? And do people understand? Seems like such a no-brainer to me. But I also know, you talked all the things, length of stay, throughput. Gosh, how many readmissions are saved?
Yes.
Yes.
All of the things, it just makes perfect sense. So I'm curious, what would you say is your biggest barrier to getting this to launch?
Just accessing those executive leadership teams.
Yeah.
Getting to those financial stakeholders. So with my podcast, I have a lot of bedside clinicians that get it. They see it. Now they're mortified by what they're doing, but they're one lone, I call revolutionist on their unit. So they come to me asking for help. Then I say, okay, bring this information, this and this to your department lead, to your nurse manager, to your medical director, your department director. And then I try to get them to then go up to the chain of command. Yeah. So it's really nice to have revolutionists already on the units when I go to train, right? I'm just breaking down the barriers for them to go through and lead this. But in the end, you have to have executive leadership teams on board. So that's been my crazy challenge because we know that the bundle, even in lower compliance, decreases costs by 30%, decreases 7-day mortality by 68%, decreases readmissions by 46%, increases discharge to home by 36%. And so it just feels like these people are up in their suites going, how do we fix all these problems? And I'm banging on the door saying, I've got an answer. I've got an idea. Let me in. But I just don't, it's been a challenge to access those decision makers.
Yeah.
So I want to call out two things that I've heard you say. One, crazy courage, right? That's one of the things that we love to say on the podcast is you've had crazy courage, right? And you carry it with you and you're empowered. And I love that you're empowering other clinicians to carry their voice and to figure that out. I think the other thing that I really want to just call attention to that you've said on this podcast that was very impactful for me is the need for financial knowledge and acumen in your practice, right? So as a clinician, as a leader, as a nurse practitioner, I think it's very important that we really hear what you're saying is that you have to figure out how does it impact the health system financially so that you can have that advocacy and grant and get those resources for your patients to be able to support them the right way. So I just want to thank you for dropping those pearls and really, doing that hard work, because that is hard work that has to be done and information that we have to pull out to be able to better partner with our leaders who are not clinical in nature and don't really see those patient safety implications the way that we do from a clinical standpoint. And I think long-term, long-standing nurses and nurse practitioners have really had the view of the patient always at the forefront and not necessarily thinking about the financial implications, and that you have to talk that language to get what you need to care for your patients. And that sometimes that's the first conversation that you have to have. So I really have a lot of respect for what you've put together and how you're packaging that ROI and having that conversation to help our, organization, our health system leaders to understand, like, hey, this is how it benefits, and this is how we can really actually have, positive outcomes for our patients.
Oh, you hit the nail on the head. I love what you're doing for patients, for families, for communities, all of that. But I don't know if you recognize how powerful this is about speaking to the value of nursing. And I've really just been on a mission lately. There's so much great work going out there, and we have such a hard time articulating what is the value. And we spoke to someone recently on a podcast about reimbursement for nursing. And I don't know the answers to how we're going to fix that and all the staffing, but I think this is such a great start to be able to quantify the value of what nursing does every day. And yes, it's the whole team, but nurses have to drive this. So I just applaud you for helping demonstrate a role model, what it looks like to say, here's the impact that we can have on a large scale, whether that's financially, but mostly for patient outcomes.
And I speculate, we don't have research on this yet. I'm hoping teams that I've trained look back at their data, but I speculate this is going to help with staff retention. Mm-hmm. One of the reasons nurses leave is because they don't get to see success with their patients. They're working so hard, relentlessly, and they don't get to care for patients the way they want to. Now, when we use this to make sure that there's safe staffing, that there's enough support, we're all working together efficiently, the entire team is helping care for these patients, nurses feel supported, they get to see their patients do well, they get to realign with their nursing values. And I worked with nurses in the Awake and Walking ICU that had been there for over 30 years.
Yeah.
Because they could care for patients the way they wanted to there. They also knew that if they went elsewhere, they couldn't provide that kind of care because no other team was doing this. And so that's what I hear from nurses, especially after this transformation, like 6 months down the road, right? Once they start to really get good at it and it becomes the standard and the norm, the team is finding their groove and it's not so hard anymore. They're like, oh my gosh, this is fun. This is awesome. I'm showering my intubated patients. I'm taking them outside. Like, we kind of take the ICU bad A mentality away from just running codes to who can take the sickest patient to the window to do the most humane thing, and who can get their patient the most awake and the most mobile. Like, it just kind of reinforces that competitive spirit towards how can we be the most humane, who can do the most creative, the most fun, the most kind, compassionate thing for their patients. And that brings in this whole new environment. When I go into teams initially, again, they're hesitant. They're not happy to see me, right? When I go back to visit later, they're like, come look at this patient. And they want to brag. They want to show off. They have cool stories. Like, they're proud of themselves. And you can see their countenances look different.
Yeah.
So I just speculate that has to play into staff retention because they feel more supported and united as a team. They have better patient outcomes. They're providing better care. And those soft skills that it feels like administration doesn't care about. It feels like administration doesn't care about having the time to sit there and hold your patient's hand and help them write on a clipboard. When you change that environment and they have that time and that capacity, I just know that I as a nurse was like, yeah, this is what I got into nursing for. And you watch your patient successfully extubate and walk out the doors, and they know, because of the training, they know very clearly that they made that happen, that it could have gone differently. But as a team, they stopped all this harm from happening. There's so much pride that comes with that I think, yes, obviously financially, that hospitals benefit, but a sustainable workplace environment and team is invaluable. And that's what they get to build when they practice humanized medicine in the ICU.
Well, I think, we all need to really bring that back to the workplace as a whole, because the hospital can be a really tough environment and it can take a lot out of you. So, I think when you can see positive patient outcomes, it does reinvigorate you and reinfuse, like, okay, this is why I got into this. This is why I spent time studying and learning and really just giving you that fire back to fuel you to continue to, show up the next day, even for the hard days. You can push through because there are going to be more good days than bad. So I think that's so powerful. Well, okay. So on the Healthcare Rule Breakers podcast, number 1, I'm so grateful to welcome you to the Rule Breakers Club. Yes. This has been a fun one. But we want to hear from you as far as, like, if you could break one rule in healthcare, what's it going to be?
I know this sounds insane, but it's because it's not really a rule. It's made up. It's not a rule. Those are the most important rules to break. But we have this rule in the ICU that every time you intubate a patient, you have to immediately hang continuous sedation. So one rule I really focus with teams on to break is to not automatically hang that. Or if you give a paralytic, obviously you have to give something in the interim. But as soon as there's no indication for sedation for most patients is shortly after intubation, let them wake up. The new rule should be let patients write on a clipboard as soon as possible to tell us what they're experiencing and what they need. If you break and create those rules, you will completely change the trajectory of a patient's hospitalization and life, as well as the staff's workload. That continuous sedation increases the risks of delirium by 216%. Is it really necessary? That rule was made up in the 1990s when we were giving insane ventilator settings. Yes. We changed the ventilator settings, but we somehow kept that rule. And so we've got to update that rule. It wasn't even a rule. I hate even calling it a rule, right? But when we break that rule, we open up the door for so many other interventions and to really master the bundle. So we rolled out the bundle, the ABCDF bundle, but we kept onto that rule. So we tried to make that rule fit into the bundle because we didn't want too much change. We didn't want to go too crazy. But if we'll break that rule, we can then master all of the other elements of the bundle and really thrive.
So I think most rules that we encounter are not written rules, right? They're rules that we've made up along somewhere across the pond. We've made them up. We've put them in place. We've put them in practice, and then we've not done the work to undo the unwritten rules. So I completely agree. Whether it's written or not, it's been passed on like a sacred cow. It's been passed on and passed on and passed on, and we haven't gotten rid of it. So I agree. It's time to really reevaluate and update our processes and policies and even our ways of thinking. Like, those can be rules that we don't even know. We're just living and dying by them, but we don't really know why. Okay, so if people are looking to get in touch with you, they're looking to connect with you, they're looking to find you, they're looking for resources, how do they do that? How do they find you?
They can go to www.daytonicuconsulting.com.
Okay.
You can book a meeting with me there. There's a lot more information about my team and myself, as well as transcripts for the podcast. You can search by topic. There are lots of resources related to this topic, but also access to me.
Okay.
I love that.
Are you on LinkedIn or anything like that? Can people connect with you on there as well?
All of it. Yep. Absolutely.
Okay. All right. And we'll be dropping the links to those social media platforms and the website when we drop the podcast, so people can definitely access you from those clickable links.
Yeah, I'm so grateful for your time, for the work that you're doing. And I have to just close with the final thought of, my world is all leadership and administration and supporting those leaders. And I hear and feel the pain of those administrators that are making those decisions, right? At some point we talked about, oh no, we've cut our rehab department and we need to implement this, right? And so I empathize with those heavy, heavy decisions that they're making. And I think that if any of them are listening, to just hear, we know in business you have to spend money to make money. This is it's a little bit of a risk, but it's like an insanely calculated, like, go for it, make the change, watch what happens on that back end. So I empathize with their decisions that they make, but this is just such a great way to talk about the value of that investment.
And if they want to listen to other success stories from the teams that I've trained, we've got numbers on a lot of them. They again spent thousands to save millions.
I love it. Thank you so much for sharing your story and the work you do.
Thanks for being with us today.